General principles: pain is subjective and therapy must be individualized. Chronic pain may not be associated with any objective physical findings. Pain scales can be employed for quantitation. Treatment: acute pain usually requires short-term therapy and often improves with acetaminophen or NSAID-based regimens. Chronic pain requires multimodality management to keep opioid use to a minimum to prevent risk of dependence and subsequent escalation of opioid doses. Higher doses of opioids have been shown to increase the risk of overdose without providing increased pain relief. 9 If pain is refractory to medical therapy, then non-pharmacologic modalities, such as nerve blocks, sympathectomy, and cognitive behavioral therapy, may be appropriate. Opioid analgesics effects. Opioid analgesics are pharmacologically similar to opium or morphine and are indicated for moderate to severe pain. Dosage. Table 1:1 lists the analgesic dosages. For acute pain management, the lowest effective dose of immediate-release opioids should be given. Patients with demonstrated tolerance often require higher doses. Use of non-opioid pain medications and non-pharmacological pain management strategies to minimize opioid needs is encouraged. Both parenteral and transdermal administration are useful in the setting of dysphagia, emesis, or decreased gastrointestinal GI absorption. Patient-controlled analgesia often is used to control pain in a postoperative or terminally ill patient. Opioid-naive patients should not have basal rates prescribed due to risk of overdose. If a patient requires continuous basal analgesia, supplementary PRN doses for breakthrough pain of roughly 5 to 15% of the daily basal dose can be provided. If frequent PRN doses are required, the maintenance dose should be increased, or the dosing interval should be decreased. Severe pain uncontrolled with large doses of opiates, particularly while using patient-controlled analgesia with basal rates, may warrant consultation with a pain specialist. Opioids are relatively contraindicated in acute disease states in which the pattern and degree of pain are important diagnostic signs, e.g., head injuries. They also may increase intracranial pressure. Opioid dosage should be adjusted for patients with impaired hepatic or renal function. Drugs that potentiate the adverse effects of opioids include phenothiazines, antidepressants, benzodiazepines, and alcohol. Tolerance develops with chronic use and coincides with the development of physical dependence, which is characterized by a withdrawal syndrome when the drug is stopped abruptly. It may occur after only 2 weeks of therapy. Administration of an opioid antagonist may precipitate withdrawal after only 3 days of therapy. The quantity of opioid tablets prescribed at discharge should not exceed the expected duration of pain. A quantity to cover 3 days or less should be sufficient. Prescribing a quantity at discharge to cover more than 7 days duration of pain should not be necessary and is discouraged. 9 Adverse and toxic effects. https://trunctam2oc.com/Central nervous system effects include sedation, euphoria, and pupillary constriction. Respiratory depression is dose-related and pronounced after IV administration. Cardiovascular effects include peripheral vasodilation and hypotension. GI effects include constipation, nausea, and vomiting. Stool softeners and laxatives should be prescribed to prevent constipation. Opioids may precipitate toxic methacholine in patients with inflammatory bowel disease. General urinary effects include urinary retention. Pruritus occurs most commonly with spinal administration. Opioid overdose. Naloxone, an opioid antagonist, should be readily available for administration in the case of accidental or intentional overdose. Naloxone home rescue kits have been shown to reduce opioid overdose mortality. 10 patients being discharged home on more than 50 morphine milligram equivalents per day have a higher risk of overdose and may benefit from a prescription for intranasal naloxone at discharge.